ocular trauma is perhaps the very first topic that comes to the purview of a first year resident as the first line person who's handling those cases in the ward. And that is why this topic sort of takes importance to ophthalmology, because if you're working in any of the government setups or even in centers which are purely ophthalmic in their practice, even they would have ocular trauma services round the clock many times. And the resident who has just joined is the first to reach at the scene. And at such a time, he is really, sort of surfing the sea in a uncharted territory. So let's see how to surf better. And so I have no financial interest. There are myriad type of presentations of ocular trauma. They can be associated with injury to the entire body, which are cases which could be coming in as a reference from the polytrauma wards. There could be dog bite cases, there could be chemical injury. There are myriad causes, and our only aim for this particular presentation is that you are able to have good results in your career wherever in whatever position that you are in currently. Even if you are a first year resident, you have to work hard enough to be standing for your patient. If you are somebody who is in a position of being able to operate as maybe a third year resident or a fellow, then also our guides would hopefully improve your results with your patients. So coming into the very first thing that I wanted to share with everyone was the resources that we begin with to study. So people talk about surgeries and everything, but nobody really highlights the resources. So in your very first introduction to ophthalmology in the first year, perhaps Parsons and Kansky are the two books that people pick up initially, and then they move on to the other books. So there are good chapters given in both Kansky and Parsons on the topic of trauma. They are very limited, and they would serve as a good primer. Thereafter, you can move to the basic textbooks like Albert and Jacobi's, and the trauma textbooks that, like, I read a lot from Shingleton, and there are other textbooks. There are eye and emergency manuals. It depends on what is the trend in your institute, but ultimately you have to give good results to the patient. The other resources that are there are the various trauma societies. So we would begin with the Indian Registry of Eye Injury, and it is an endeavor taken up by the Ocular Trauma Society of India to sort of create a database of ocular injuries. And they have certain videos also on their website, and it is a very useful source. After that, we should look at the International Society of Ocular Trauma. As you can see, they have a very interesting logo in which a bullet is passing through the globe. So that's how I used to remember it in my residency. And then there is the United States Eye Injury Register, World Eye Injury Register, and the Birmingham Eye Trauma Terminology System, the BETS, which we'll be taking up in detail later. So these are the certain websites and certain resources, the Shingleton Trauma book and these websites that would be a good guide to starting off your surgeries and reading in detail. So coming on to the salient point of approach to a patient, the very first task of the first responder should be to ensure medical and neurological stability of the patient, particularly in cases that are involving, say, trauma to the other parts, or if there is a fall from height and the swelling is mainly ocular, but there could be an indication of a head injury. Hence, ensuring that the patient is stable in their overall condition is the first priority. And if needed, you should send the patient to neurosurgery, general surgery, or wherever the patient will get the better care. The chemical injuries is a totally separate topic, but it's a condition that requires emergent attention with copious irrigation before taking detailed history and performing examination. The acute retrobulbar hemorrhage has to be treated urgently, and IOP lowering agents and canthotomy are the immediate treatments. Open globe injuries will be, first of all, at the outset, they need protective shield, they need prophylactic antibiotics and tetanus, and again, all this has to be done only after ensuring the medical and neurological stability of the patient. The appropriate imaging has to be done to rule out IOB fractures, and then that is a topic that will be taken up by Dr. Nupur in detail. And the relevant medical history of the patient. Why is the relevant medical history important? A patient could be, say, having a stent, and we are asking the patient to go and get certain kinds of imaging done. There could be patients who are having seizures. There could be other systemic conditions which could prohibit certain medications, certain procedures, anesthesia. Hence, medical history has to be taken at the outset after provision of the first care at the presentation of cleaning and providing first aid. So I'm this is a kind of general classification which we are all aware of: mechanical, non-mechanical. The non-mechanical this is not a topic for the non-mechanical. We are going to deal primarily with the mechanical, which could be involving the adnexa or the globe. The associational could be involving the other systemic body parts, and environmental, like the sort of a cause where is the injury taking place, whether it was while playing, whether it was while driving, whether it was on the field, whether it was at the time the patient was at a workplace, occupational hazard sort of a thing. And we need to classify it according to the part of the eye involved, whether the injury is closed lobe or open lobe. We'll see that in detail. And then what is the basic, the pathology, and then we have to do the detailed classification. So how do we begin the classification? We have to begin by a meticulous history taking. And for mechanical trauma, we have to first ask about the object that has caused the injury, whether it was sharp or whether it was blunt. If the eyeball has been affected full thickness, or it has not been affected full thickness. If it has not been affected thickness, it would be a contusion. Otherwise, it would result in a rupture. If the object was sharp, whether it has caused a full thickness tear or a partial thickness tear, has the object left the eyeball? So many times we ask the patient and they would give a history of hammer chisel injury. And the hammer chisel injury, this is a practical pearl, but the hammer and the chisel. So at that point of time, when the patient is working and that kind of an injury is there, a workplace injury, the part of the part that goes into the eye is not a part of the stone. It is generally a part of the particular hammer, and it goes very fast into the eye and is generally sterile because it gets heated up. It's a mechanical injury, but it is being caused by the object that's being hit, not by the object that is being hit. So by the object that we are using to hit, that is the part that is going to go inside the eye. Now coming to the vet system. So the major classification at the outset has to be a closed globe and has to be an open globe. So closed globe would be primarily a contusion or a lamellar laceration, and open globe would be a laceration or a rupture. So lacerations would be broadly penetrating, intraocular foreign body, and perforating. Now if we get to the overall definitions of ocular traumatology terms, the eye wall, which is the cornea of sclera, and it has to include the three tunics of the limbus and the other sclera and the cornea. The closed globe, the eyeball will not have a full thickness wound. The open globe we have already discussed, and rupture is when the eyeball is being hit by a blunt object. Coming on to the various terminologies, the laceration is a full thickness corneal or sterile wound caused by a sharp object. Penetrating injury would be a single full thickness wound of the eyeball with no exit wound. Intraocular foreign body would be causing a single entrance wound if it is retained in the eye. Perforating injury, two full thickness wounds would be there, and contusion would again be a closed lobe injury. So the lamellar laceration would be a partial thickness defect of the bulbar conjunctiva or eyeball. Superficial foreign body will be having the force of the impact would be blunt, sharp, or both, but it is not going to penetrate the eye, hence it is going to be a closed lobe injury. So what is the importance of indicating the tissue of reference? If you see here, the first injury is a closed lobe injury. It is penetrating just the layers of the cornea, but it is not crossing into the globe. Whereas the second injury, the B part, is perforating the cornea and penetrating the globe as well. So coming on to the International Ocular Trauma Classification, it was based on the BED system and features of globe injury at initial examination. They have defined by using 4 parameters. What are the 4 parameters? The type based on the mechanism of injury, the grade, which is going to be visual acuity at initial examination, the presence or the absence of a relative apparent pupillary defect, the extent, that is the zone of the injury. So the first part of it is the open globe injury. As soon as you have determined that the patient has an open globe injury, then we have to say whether it is a rupture, penetrating, intraocular foreign body, perforating, or mixed. This is the first part that we have to define: A, B, C, D, E. Then the grade of the visual acuity. Then the pupil, whether there is a relative apparent pupillary defect or it is not present in the affected eye. Then the zone. the zone. How do you define the zone? So if an injury is only confined to the cornea, including the limbus, that would be a zone 1 injury. The zone 2 injury is corneoscleral limbus to a point 5 mm posterior into the sclera, just the 5 mm from the limbus up to the sclera, and anything that is posterior that 5 mm is going to be a zone 3 trauma. The zones could be mixed. A patient could be having an injury involving both the zone 1 and 2. A patient could be having an injury involving only zone 2 and 3. So, or it could be involving all three zones as well. Now, closed lobe injury, again, here, as soon as you have determined that this is a closed lobe injury, we have to first determine whether it is a contusion, a lamellar laceration, superficial foreign body, or a mixed presentation. Thereafter, the grade and the visual acuity, grade of the visual acuity has to be seen, RAPD, followed by the zone. The zone in this is different from the zone seen previously. So, limbal to the bulbar conjunctiva, sclera, and cornea are the external zone 1. The zone 2 is going to be the anterior segment, that is involving the structures in the interior segment internal to the cornea, but excluding the pars plana of the eye. Now, posterior segment, all interior structures posterior to the lens capsule. So anything that is including the lens capsule would be zone 2. Again, in this particular type of injury also, there can be an intermingling of zones. There could be a patient who has sustained an injury onto the cornea, and there is a lamellar tear of the cornea, but it is not penetrating the cornea, and thereafter the lens and the zonules have also been slightly subluxated. So this kind of an injury would be having zone 1 and 2 both. Now, there is an ocular trauma score. It's rarely used, but we need to know that the trauma happens more in male and young. The site of injury again is going to depend on the patient's occupation, and it is going to be a prognostic factor also. And socioeconomic factors of the patient, the poor and the people who are not using protective screen, etc. Are, even during the lockdown, there were a lot of cases being reported from various parts of India. At least an advisory was issued by All India Ophthalmic Society regarding the use of bow and arrow after seeing Ramayana, and the laterality, the medical legal aspects of the patient, and there are certain ways to prevent injuries. That's again a huge topic. We'll go into it later, but we must be aware of the medical legal aspects of the liability, the consent, and the removal or localization of the intraocular foreign body, for which a doctor can be penalized legally. So, to begin the workup of ocular trauma case, we've already discussed that neurological and medical stability has to be taken care of. Thereafter, history and examination has to be seen. Prior ocular history. So, first sentence that has to be written in particular thing is subheading is that a patient had a good, useful vision prior to the injury now. That is very important. There could be a patient who has, say, retinitis pigmentosa and has now sustained injury. He was having a very poor vision prior to this injury, and is now also going to have poor vision. So you cannot expect a patient to come forth with each and everything himself. You have to take a prior ocular history properly. Then the investigations for general anesthesia or local anesthesia as per the case demand. The systemic fitness, these days most hospitals are taking up patients with the COVID, investigation also. Then special concerns in certain cases like pregnant women, then children, and the imaging that will be seen later in detail. So there are ways to see the patient on the slit lamp also. You can do a direct illumination, you can do a retro illumination, and you can do a sclerotic scatter, particularly to see partial thickness tears or hidden foreign bodies in the layers. And retro illumination can be done after maybe dilating also and seeing certain parts of the lens and the subluxation. And direct illumination you are all very familiar with. So if you look at this particular diagram here, this is a quick diagram that has been drawn to indicate a corneal tear, and this is a description. So this description really pales in front of this kind of a diagram, which is very, very important and useful to draw. And such a diagram can obviate very detailed notes because it's kind of self-explanatory. So what are the predicting factors? Vision and presentation is the most important predictive factor, and wound location, wound length. There are multiple factors like the cause of injury, endophthalmitis, other injuries associated, but the most important predictive factor is the vision and presentation. So what is the timing of intervention involving the globe? So absolute emergencies are defined as chemical injuries, the appearance of intraocular gas bubbles, orbital abscess, vision loss due to expanding orbital hemorrhages, retrobulbar hemorrhages, Urgent would be high risk intraocular foreign bodies and endophthalmitis. Less than 24 hours, open wounds requiring surgical closure, and within a few days would be medically uncontrolled IOP due to hyphema and lens injuries, retinal detachment involving the macula especially, and the secondary reconstructions can be done later on as well. So there are certain terms that are used in the management of ocular trauma. The tissue can be reopposed, the anterior chamber can be reformed, you can excise or remove the parts of tissue that has been damaged, particularly when there are cases of uveal prolapse. You have to reduce the hemorrhages. You have to replace, say, if the vitreous is prolapsed, you can replace it with the oil or gas. Reposition in case of a trauma that has reached you early and the iris is pretty much intact, we can reposit it. We have to seal and reconstruction of the anterior segment. These are the various terminologies which are used in the anatomical reconstruction. Now, how do you suture correctly? Video assisted course is there later, but we'll just take in a few pointers here. So you have to suture up to an appropriate depth of say 4 by 5th, or at least 80 to 90% is the general guideline which is taken up. You cannot put in a too shallow suture or a too deep suture or an uneven suture. So you have to see also the margins, whether the margins are incised. This would occur in basic glass injuries, or there are uneven margins which would occur many times in blunt trauma rupture cases, or they would also occur in trauma at in the road traffic accident cases. So such cases are going to need different types of suturing techniques, seeing the length of the part, etc. Now coming to the rules of corneal suturing, you have to the first suture is always to be applied at the known anatomical landmark like the limbus. Then you have to put in box sutures sometime, and after the limbus, generally the angles are sutured next, laceration angles, and then the pigment epithelial lines are also taken in as markers, I should say. The Rousey central bone closure will be demonstrated further, but I will just mention that the sutures towards the periphery of the cornea are longer, closer together, whereas the sutures towards the central area are going to be shorter and going to be widely spaced apart. This is the Rousey-Hayes technique of application of central wound closure of corneal wounds. Now, to reduce the astigmatism, there are various techniques. So there are application of compression sutures later on, but the simpler technique is not to go on maintaining a perpendicular. In this case, if we would have just maintained perpendicular, the astigmatism would be too much. There were people who used to take in Placido disc on the table and see how much astigmatism their sutures are causing. And if you keep moving the angle of the suture, the astigmatism would be reduced pretty much. Now, if there are stellate shaped wound, purse string sutures can be applied in case of special situation like uveal prolapse. Again, there would be a need for more sutures at a particular point instead of in other kind of simpler incised wounds. And there are techniques like close as you go, and then you have to identify the anatomical landmarks even in cases in which the lot of scleral tissue involvement is there. Now, the desired endpoint should only be a watertight chamber and not an airtight chamber. You even have to remove the corneal sutures very meticulously at a later stage. If the knots are on the surface or the sutures come loose, they will act as a foreign body and cause inflammation. And hence, you have to cut the suture with a scalpel blade and then pull on the cut end nearest the margin of the cornea with suture tying forceps. Now, these are some cases that have been operating for some time. This was a child that was injured by knife by his brother. The final vision after the removal of sutures and everything, despite such a long incised wound, the lens was also replaced, and the child attained 624 vision later on. This was a stone injury in a child, and this was a case of a spectacle injury. This is the case of a blade injury. This blade tip was inside this patient's eye, and we could see it in the CT scan also. This was removed and sutures were placed. Later on, an IUL was also placed, scleral fixated IUL was placed in this particular patient. And such cases always please you in the end when you get a good visual outcome. When they come, they are almost not seeing anything, but after a patient treatment regimen of few surgeries, few months, and sometimes even a year, you get good results. So this particular patient of mine is underwent a primary corneal tear repair, and because it was a tear that had come in very soon after sustaining the injury, so fixation with foldable acrylic PCR implant was done on the first day itself. So that is also debatable. Some people say that lens will be dealt with later, but some people have the opinion that, in cases of extensive inflammation and suspected injuries and suspected infection, the lens implantation should be postponed. But in this particular case, we got very good results, and here you can see the final outcome. We applied a RGP contact lens on this patient, and since the wound was below the below the like pupillary axis, the patient got a final vision of 6 part with the RGP, of course, not without the RGP. So at the post-op period and secondary reconstruction stage, we have to remember the three I's: the infection, inflammation, and IOP elevation before the need for other surgeries. Closed loop trauma, we have to have a look at the 7 parts: the conjunctiva, the subconjunctival space, the angle, the iris, the lens, and the posterior segment, which will be dealt with later by Dr. Avanish. There are various potential posterior segment findings following severe ocular trauma, and they will be dealt with later. Post-traumatic endophthalmitis, the most common cause is again staph epidermidis, according to various studies, and that would also be taken up later. So secondary interventions are required at certain stages, and exploration because of the suspicion of an occult scleral wound is one of the first interventions that is done. Resuturing of cranial wounds, penetrating keratoplasty, later on hyphema removal, iridoplasty. So there's a long list of surgeries that can be done for secondary intervention. And what needs to be done basically is that you need to tell the patient regarding the various surgery each and every time and counsel him accordingly. We will not go into the details of trauma, but just an overview of hyphema, because we get hyphema cases very often. So in hyphema cases, patients are advised moderate activity, laboratory tests are done, medications are given to lower the IOP, and at all such times, you need to also remember that the patient has to be examined and classified, and the surgical indications are also there. So first of all, you have to classify the extent of the hyphema, then the medical management and monitoring of IOP, whether inpatient or the patient is going to be followed up on an OPD basis, is going to depend on the kind of setup and the how far the patient is coming from. There are various indications for surgical paracentesis. They could include the IOP more than 50 for 5 days, more than 35 for 7 days, and more than 25 for 5 days, more than 50 for 2 days. And now counseling has to be done at initial presentation, after primary surgery, and prior to the secondary intervention, after any reconstructive surgery. And we also have to help the patient to rehabilitate into work and life, like those patients who have undergone a very extensive injury and have a sort of a very very deformed eyeball, which is now going into phthisis. You have to tell them how to get an implant and reconstruction to get back into a cosmetically pleasing appearance and get back into their life. So all that is also a part of our management only. Maybe it is going to happen 6 months down the line, but appropriate counseling should be done in each and every stage, and the prognosis should be explained to the patient from the very beginning, including the risks of infection and other problems. So we should just not look at one eyeball or two eyeballs. We should look at everything that is there in a patient's life, and then try to help that person as much as possible in our hands. Thanking you all for patient audience. So in trauma repair, patience is a really required, I should say, attribute that a surgeon must have. And similarly, the residents are also going to be very patient with the patient when he comes again and again and has multiple questions, and they are unable to take decisions regarding secondary surgeries, primary surgeries at all time. If we try to be patient, we are going to get good results for our patients.